Okay, how do I and why do filters clot? Well, the simplest thing is that one could take the view that the reason they clot is that we don't anticoagulate the circuit hard enough. And so if we did it with a technique that is safe for the patient and suitably aggressive like citrate, then that would be all nice and easy. And indeed, this is a recent randomized controlled trial, the largest randomized controlled trial comparing citrate to heparin protamine regional anticoagulation with about 900, almost 900 filters in 200 patients in multiple centers. And it's quite clear that if you anticoagulate the circuit aggressively and you use citrate instead of a heparin-based approach, then you almost double filter life. And so it seems totally reasonable to say that the reason that filters clot, at least to a degree around the world today, is that people don't give citrate enough. So that's pretty cool. However, I put a little arrow there, and the arrow there is to show that at about 10 hours, if you're in a heparin-based system, about 30 to 35% of the filters will have clotted. And that seems kind of provocative and interesting. You'd like to understand why there are these filters that clot so quickly. And the rest of my talk to you today is to try and provide you with some insights into why there are these complex interactions between the blood pump and the access catheter and the membrane and the filter casing, using some of the data that Ian Baldwin generated some time ago and some recent data that we've acquired by continuous monitoring of pressures in the circuit. As you know, there are lots of catheters available, and you might use different ones in your units. They have got different shapes, different lengths, and different sizes. And just like we've heard about the modality of renal replacement therapy, there is a limited amount of data on how long they should be, how big they should be, and what shape they should have. And you can see there that they can have different designs with a coaxial design, or have side holes through which they can suck blood into the pump system. And of course, we don't even know if one design versus another yields better outcomes. And this ignorance derives from a variety of difficulties in testing catheter function and a variety of difficulties in measuring flow as opposed to what the pump rotations tell you. However, Ian did some very nice seminal work using a flow probe which was hugging the tubing of the circuit and allowed us to record all of the time what was happening to flow while we were testing different catheters, and also what was happening to pressures while we're testing different catheters. I don't want to show this slide to compare one catheter to another, just to show you that in the absence of a positive venous backup pressure, as might happen in patients, in an optimal situation, as might happen in a beaker full of blood with a hematocrit that simulates what we see in critical ill patients, you've got to suck pretty damn hard to get blood out of a catheter. And that tells you already that the design of these catheters, or at least the size of these catheters that we use, is possibly suboptimal. And if you make the catheter longer, then you probably have to suck a little bit more than if the catheter is shorter. So the catheter is a trouble spot. But it's not only just a trouble spot because it's designed funny, because it is too small, because it is not long enough, but it's because we have catheter sizes that are not adjusted to body size. And so if you put a 20 centimeter catheter into a 50 kilogram woman, you might get all the way into the inferior vena cava with the tip. And that's nice. But if you put it into me, you'll probably be in the external iliac. And if you do Doppler estimates of external iliac blood flow, if somebody is lying in bed, it's about 150 to 120 mils per minute. So if you've got your catheter in there and you ask you for 200, it ain't going to happen. And what's going to happen, particularly if you've got side holes, you're going to suck the walls of the vein into the catheter, and the more you want and the less you get. So there is clearly a problem with the catheter in this regard. And of course, then the catheter will interact with the pump technology. And the pump technology that we have used until now and continue to use is based on a roller system, where you're squashing the tubing that is surrounding the pump. You create, during the rotation, a squash of the tube, which generates a suck pressure to refill the tubing and allows the blood to move forward or outside of the circulation with a progressive squash and refilling of the tubing. Now again, this relationship between catheter and pump matters a great deal, because you see, the machines that you have will measure the rotations of the pump, but they're actually measuring the actual blood flow that might or might not be taking place while the pump rotates. And so Ian nicely, some time ago, put the system to a test with a flow probe around the tubing, and we were able to graphically display what might be happening under circumstances of suboptimal catheter function, which are then reflected in some of the pressure characteristics of the pump. And you can see that I scribbled in there is a patient having a nurse change position in this patient, and you can see that there is quite a dip in the negative pressure that is being applied to the circuit. And of course, the fall in blood flow is beautifully manifested in this systolic-diastolic system, and you see that you have periods where the blood flow almost disappears. And you can squash it and show it over a significant period of time, and you can see that you have systems and situations where the machine does not actually know, you don't actually know, the nurse doesn't actually know, the patient doesn't actually know, but the actual flow, despite the rotations of the pump, is dissociated from the pump rotation. And of course, if the flow is less and the ultrafiltration is the same, the filtration fraction goes up, the membrane gets caked up with layers of platelets and red cells and proteins which are being sucked very hard during effluent creation, and over a period of time you're going to lose the filter. Is that real? Is that really true? Yes, the answer is absolutely so. So the more time you spend in flow reduction, the more trouble you have, and different sites of catheter insertion are more prone to flow reduction, particularly the subclavian position is prone to flow reduction. Do nurses do things to patients that make flow reductions more likely to happen? Absolutely. Then nursing interventions, positioning of the patient, rotating the patient, physiotherapy as well will inevitably alter the catheter to blood flow relationship, and then will increase flow reductions. And of course, as the flow reductions increase, then the chance that the catheters will that the filters will clot will increase, and again, the subclavian position is particularly problematic. But all of this information was and is only available to you if you've got a fantastic person like Ian actually doing this kind of work as part of his postgraduate degree. But what about everyday life in your neck of the woods? I mean, can you actually get a sense about what is happening to your patients and to your circuits and to your filters every minute of the time that the filter is at work? And the answer is we now can. And indeed, you can actually have automated monitoring of pressures in different places in the circuit that can tell you very much about what's happening to your filter and circuit as time goes on. And this is the Prisma machine, and you can download from the back of the machine electronically all of the data every minute for the access outflow pressure, the pre-filter pressure, the post-filter pressure, the effluent pressure, and the transmembrane pressure, which of course is calculated. Cool. And that's downloadable, can be displayed graphically, and it gives you something like this. So this is a circuit at work, and you can see that there's the transmembrane pressure, the pre-filter pressure, the post-filter pressure, the access outflow pressure, and the effluent pressure. And you can see the filter starts out at an effluent pressure about 0. It's imbalanced. And then as the filter gets a bit older, you're beginning to suck. The effluent pressure is being generated in order to give you the effluent load or the effluent volume that you want. And then the filter starts to clot, and progressively the effluent pressure that you have to generate to get the ultrafiltration that you want needs to go higher. And of course, this is a self-fulfilling cycle in the sense that the more you're applying effluent pressure of a negative kind to get the flow that you want, then of course the transmembrane pressure goes up, and the more the transmembrane pressure goes up, the more you're layering the membrane with proteins and platelets, and therefore it is harder to get the ultrafiltrate you want, therefore you have to suck harder, and therefore you make the membrane fatigue faster in a cycle of unhappiness. So, taken that technology now, we've looked at a cohort of patients, mechanically ventilated sick patients in our ICU, and we looked at about 70 filters in 23 patients. And we've been able to very, very nicely see that there are different patterns of what we call artificial kidney failure. So you can have acute artificial kidney failure. You can see there that there is an acute problem with your outflow access. All of a sudden, something happened to this patient, and the outflow pump was sucking at about minus 350. You're just not getting the blood. And, of course, that episode has a price. Within about 2 or 3 minutes or so, you've lost the filter. So you've almost certainly had an episode of stagnation of blood, and you lose the filter. Or you can have subacute artificial kidney failure, and you have a few problems with access here and there, and you slowly, progressively pay a price. There is clotting progressively with the effluent pressure becoming more negative, and the transmembrane pressure going up until at about 16 hours or so, you lose the filter. Or you can be happy, or relatively happy, and again you see a progressive loss of filter membrane function, with the yellow bit being the effluent pressure, and a progressive application of the negative pressure to this membrane, and a progressive, slow, steady increase in transmembrane pressure, indicating progressive, slow coagulation of the membrane, and you lose this filter at 36 hours instead of 10 hours. And so you have these three patterns that you can very clearly see in the patients. So you overall have a filter life of about 18 hours, but within that filter life, there are these three groups of patients. And there is a group of patients that does very well with progressive membrane fouling and clotting, and a group of patients that do very badly, and essentially all of them have access problems. And you can also demonstrate and study and stretch it out, and you can study it very nicely. You can see in this slide that this access is bad to begin with. You might recall, and I'll show you in a minute, normally, these patients start out with a negative pressure on the outflow side of your access catheter of about minus 40, minus 50. This guy's already really bad. It's already minus 100. You already know before you start you're going to be unhappy. And sure enough, very quickly you're down to minus 250 and so on. And you can see the effluent pressure becoming negative very, very rapidly with a very fast negative gradient, because the membrane is clotting very rapidly, the transmembrane pressure going up very nicely. This is an axis which, as you get, starts out nicely about minus 50, and then something's happened there. There's a step down. Something's happened where the patient changed position. We're not sure. And then now it starts to play up. It's become bad. And now you have episodes of significant negative pressure on the outflow side, and you immediately pay the price, and you lose this filter as well. Or you can have mild episodes, just a little bit of episode here, a little bit of in an otherwise happy access catheter. But you can see that even small episodes there change and tilt the effluent negative pressure very quickly, and you start paying a price even for that short-lived episode, and you have to apply more negative pressure to get flow through the membrane because it's beginning to clot. And it's not a surprise, it shouldn't come as a surprise to you that if you compare the filters or the circuits with acute or subacute dysfunction versus chronic, those with acute dysfunction have a lot more of time and severity of access outflow problems, and that shouldn't come as a surprise. And conversely, the circuits or the filters where there is more access outflow dysfunction, whether it's mild or severe, are more likely to last a short time. And then you can compare all these different patterns very nicely, and you can see that access outflow at the very start is more negative in those that last for a short time. Variability is greater, and the gradient of change in transmembrane pressure is greater, all consistent with the hypothesis that access dysfunction is fundamental. And when you look at multivariable models to predict filter life, access dysfunction and fluctuations of greater than 10 millimeters of mercury in access outflow pressure are very powerful predictors of your filter life, and they matter a great deal. And this is another way of displaying the filter life when comparing filters with mild or moderate or without access outflow dysfunction versus those with moderate and severe access outflow dysfunction. And you can see there's clearly a big difference. When you look at pressure variability as another marker of the fact that your access is not robust, you see again the same pattern. The more variability there is in access outflow pressures, the more trouble you're going to be in. So let me conclude by saying that not all circuits fail through the same mechanisms. In some circuits, access dysfunction is fundamental. In others, you're dealing with progressive, slow clotting of the membrane. In others, there is a combination of both in different proportions and with different intensity. It is now possible to do pressure analysis on a continuous basis, to display it graphically in order to make the correct diagnosis as to how and why your filter clotted. I read about it in a book when I did medicine that the correct diagnosis allows you to deliver the correct treatment. And clearly, if your response to a patient that has access outflow dysfunction is to double the anticoagulation that the patient is exposed to, that's a bad thing, because you're exposing the patient to the dangers of that intervention without any credible probability of benefit. Equally, to try and change the catheter in somebody who's actually got adequate catheter function to deal with a problem of progressive clotting is a wrong thing to do. And so, like in every aspect of medicine, making the correct diagnosis is crucial to delivering the correct therapy. Thank you very much.